Okay. Okay. So hi guys, how are you? So today we are going to do a session on FMG most important questions that can be that can come in FMG. So let's revise. Let's see how good your revision is. So this is like an online quiz. So we are going to do an online quiz on how well prepared you are. So let's quickly start. So everybody's going to answer. Okay, so this is going to be an interactive quiz. Let's revise. Let's see how good your revision is. So this is like an okay. So yes. So let's quickly do it as a quiz question. Yes. So people who are asking, is it good for NEET PG? So it's like a quiz. If you're able to answer, that means you're good prepared for NEET PG. You're well prepared for NEET PG. So let's quickly do it. I'm not going to waste much of your time. I'm going to finish the session very quickly, and it will be like a quiz. So ready? On. Let's start it. Okay. So here's the question. Okay, and everybody's going to answer quickly, real quick. Okay. So let's see. Read the question and you're going to answer. Take it as an exam. Okay. So this is a 36-year-old man who presents with fever and painful joints. So there's a fever and painful joints. Okay. Physical examination. Just a second. Just a second. Yeah. Okay. So patient presenting with fever and painful joint. Physical examination shows glossitis, angular cheilitis, lymphadenopathy, and patient has lost about 9 kgs of weight, and his stools are pale and foul smelling. Blood cultures are negative, and there is a marked improvement with the antibiotics. Biopsy of the small intestine has been taken, and it shows the following. What is the diagnosis? Quick, everybody. Let's see. So quick, everybody. Is it okay? Yeah, you can see. Is it zoomed, Bijender? Is it okay? Yeah. So tell me, what's the answer to this question? So yes, everybody, you're correct. So this is Whipple's disease. So remember guys, this is actually your lamina propria. So this is your epithelium, isn't it? So just below the epithelium, we have lamina propria. And in the lamina propria, we have lots and lots of macrophages. And in the macrophages, there are small, it's bacilli are there, okay, bacteria are there. And these bacteria, okay, so what is that bacteria? Who's going to tell me that? Trophirema whippleyi, okay. So these macrophages basically eat that up, and that you can see. Very good. Right? Okay, so that's your Whipple's disease. And what's the special stain for this, guys? Yes, it is PAS. Very good, it is PAS. Amia Nayak, you needn't attend the session, please. You're already a DM, okay? Right, okay. So, PAS positivity is seen in this macrophages, okay? So, who's going to tell me what is the growth factor which is involved in Meningitis disease? Quickly, what is the growth factor which is involved in Meningitis disease? Yes, TGF alpha. That's very good. It's TGF alpha, which is a growth factor for Meningitis disease. Okay. Now, one more very important cause of malabsorption that is asked in the question is this. So, who's going to tell me the answer to this question? Let's see. This is the normal intestine. And I'm giving you the same question. A person has malabsorption, but it doesn't improve with antibiotics. And this is the biopsy that you're seeing. Okay. So, I'm not asking you the disease, I'm asking you what is the predisposing HLA molecule associated with it. Who's going to tell me this? Quickly. Quick. What is it actually? So what do you see here, everybody? So normally small intestine has lot of villi, isn't it? And there are crypts. So here you can see that their villi have become flattened. The crypts have become elongated, and there are intraepithelial lymphocytes. Intraepithelial lymphocytes. So who's going to tell me what are these lymphocytes? Quickly, what are these lymphocytes? CD4 or CD8? So remember, they are predominantly CD8. Next question, okay. Also, they can be NK cells also here. So next question, which interleukin is produced by the epithelium which stimulates T cells and NK cells? So this is interleukin 15. Remember, all these are questions, okay. So epithelium releases interleukin 15 that stimulates CD8 cells, okay. And remember the 3 points here. So there is flattening of the epithelium, elongation of the crypts, and intraepithelial lymphocytes. So these 3 points are very characteristics of celiac disease. But remember, biopsy is not hallmark of celiac disease. You have to have serology also positive. So biopsy plus serology will make the diagnosis of celiac disease. Okay, so everybody should know that. Okay, and what is the HLA molecule? Quickly, HLA molecule. Quick. What is it? It is DQ2. Yes. Okay. Right. Now next spotter for everybody. Let me ask you this question. Again, a biopsy was taken from large intestine. Don't worry, Veera. I am able to see your messages. So now next question is the biopsy was taken from large intestine. Again, a patient has an history of disturbed absorption or malabsorption, and this is what you see in the biopsy. And what are these? Quickly, everybody, what do you see in the biopsy? Quick, I'm just waiting for you. What do you see in the biopsy? Very nice. This is something. What is this called? This. Quick, I'm waiting for the answers, guys. Come on. What is this ulcer called? What is this ulcer called? Quick, guys. I'm still waiting for you to answer. Yes. So why this ulcer doesn't go deep? What is there? What is this ulcer? Yes, very good. So this is Mohan Singh perfectly answering first. It is flask-shaped ulcer. Okay. So this ulcer, it cannot penetrate the muscle. So it spreads in the submucosa only, and that is why it is flask-shaped. And yes, you can see trophozoites of entamoeba in it. And the point to identify this is that it has erythrophagocytosis. Okay. Yes. And please everybody, you should remember, they are also PAS positive. So the points to differentiate Whipple's from amoebic colitis is first, Whipple's is a disease which occurs in the small intestine. Celiac disease occurs in the large intestine. Number 1. Number 2, erythrophagocytosis inside the, so erythrophagocytosis, whenever you see, you can be very sure that these are trophozoites, okay? Whereas in PAS, whereas in cases of Whipple's disease, there will be macrophages, but if you do electron microscopy, you will be able to see a rod-shaped organism or a broken up pieces of the organism. This is Trophirema whippleyi, right? So that's the catch point and differentiating, right? Yes, very good, Nikhil. Anchovy-pus is seen typically in the liver, right? Let's go to the next question, everybody. Let's see if you can answer this. A 17-year-old woman suffered a blunt abdominal trauma in the motor vehicle accident. Okay, sound is less, okay. Is it okay now? Is it okay now? Yes. Yeah, now see. So let's look at the question. A 17-year-old female with blunt abdominal trauma, on admission her hemocrit was 33, but next hour it decreased to 28%. Paracentesis revealed a serosanguinous fluid. She was taken to the surgery department where a liver laceration was identified and 1 liter of bloody fluid was removed. She was stabled. CBSE was performed 3 days later. And what do you think will be the morphological findings in this case? Yes, Amiya Nayak, I hope you can answer this question now. So what is the answer to this question? Quickly. So what do you see? So 17-year-old person, hematocrit is falling very rapidly, okay, had a blunt trauma, bloody fluid in the peritoneum, okay. What will be the peripheral smear finding? Yes, quickly. What will be the peripheral smear finding? I am waiting for your answers, guys. Let's see who answers first. Very good, Veera. So, answer is reticulocytosis. Okay, so everybody should know the answer to this question is reticulocytes. So, what are the causes of reticulocytosis is one question that they will answer. They will ask you. So, reticulocytes, whenever they are increased, remember the two differential that you should always remember is either there is increased production by the bone marrow, like in cases of hemolytic anemia, or acute blood loss. Okay, acute blood loss. And second is if you remove the organ which eat it, that is splenectomy. So, post splenectomy also you will get reticulocytosis. So, everybody should remember at least these cases. Hemolytic anemias are one of the very important causes, acute blood loss and post splenectomy. These three you should always remember as important causes of reticulocytosis. Okay. Now, Again, another question that they ask you. Okay, there are a lot of questions which come from this diagram. Okay, so everybody knows erythrocyte maturation. Okay, so once there is a hematopoietic stem cell, the first cell that comes here is proerythroblasts, and then there will be BPO, that is basophilic, polychromatophilic and orthochromatic erythroblast. This will be followed by reticulocytes, and then it will form the RBCs. So let me tell you what all questions come in this, okay, to you. So first, so which is the first cell, okay, which is produced without the nucleus, okay. So remember, it is a reticulocyte. The pycnotic nucleus is present in orthochromatic, okay. Pycnotic nucleus is present in orthochromatic, okay. Everybody should remember, okay. Next, you should always remember that the reticulocyte has only RNA. How many days does it spend? So reticulocyte spends 3 days in the bone marrow and 1 day in the peripheral blood, okay, for maturation. And then, okay, then it goes to the spleen where extra membranes are removed, and then it changes into RBC, okay. Also, you should remember here one more question that can be asked to you in exam. Parvovirus, okay, parvovirus, if it infects, okay, parvovirus, if it infects the erythroid series, proerythroblasts are affected, and these proerythroblasts become giant proerythroblasts, okay. They become giant proerythroblasts, which can be seen. So once that happens, whole of the production of the erythroid series will be lost, and this, okay, can cause red cell aplasia. This can cause red cell aplasia, okay. So giant erythroblasts can be seen, and this can be seen in red cell aplasia, pure red cell aplasia, okay. So that's about this. Let's look at this cell. So who's going to identify this cell? Quickly, let's see if you can identify. Guys, you can hear me? Guys, you can hear me? Yes or no? What is this cell? Quick. Yes. What is this large cell here marked with an arrow? Quickly. A live bird, yes. The drugs which cause hemolysis, okay, can cause commonly anti-malarial drugs which can cause, you know, hemolysis, can cause reticulocytosis, okay, right. So what is this cell? On the peripheral blood. This is peripheral blood, large cell. Guys, look at the color of this cell, okay. It is little bluish, okay. It has tinge of blue in it, okay. So this is a polychromatophil, okay. So polychromatophil is the other name of reticulocyte. Polychromatophil means some cell which has multiple colors. Polychromatophil, multiple colors. So this is the other name for reticulocyte. So question number 1, can you see reticulocytes in the peripheral blood? Yes, you can see. You can see them as polychromatophils. Can you confirm that these are polychromatophils? No. For confirmation, you need a special stain. So the special stain which we use here is a supravital stain. What is a supravital stain? Supravital stain is a stain where the maturation keeps on going, okay. So cell keeps on maturing also. This is called supravital stain, and the best supravital stain that we use is new methylene blue. Okay, so best supravital stain that we do is new methylene blue. That's it. Okay, apart from that, brilliant crescile blue is also very good supravital stain, but we predominantly use new methylene blue. So what do you see in this? You can see this reticulocytes in this, okay, which can be seen inside the RBCs. So that confirms your reticulocytes. So you count 100 RBC and you give them as percentage of reticulocytes, okay. So apart from that, you should remember we have corrected reticulocyte count, which is reticulocyte count multiplied by the RBC count. Where do you need corrected reticulocyte count? For grading in aplastic anemia, okay. So in aplastic anemia, if your reticulocyte count, corrected reticulocyte count is less than 20,000, then that means that this is one of the criteria for aplastic anemia, okay. Apart from that, Okay, so this is one more point here. This is guys, this is absolute reticulocyte count. Okay, so this is absolute reticulocyte count. What is a corrected reticulocyte count then? Corrected reticulocyte count is the reticulocyte count multiplied by the hematocrit of the patient by control hematocrit, and control hematocrit is usually 45. So they usually give you a lot of MCQs on this, like they can give you, I'll say, a hemoglobin of the person is 5 gram per deciliter and the reticulocyte count is 6%. Calculate the corrected reticulocyte count. So how will you calculate? Remember always, hematocrit is 3 times the hemoglobin. Okay, so this means 5 into 3 is 15. So corrected reticulocyte count will be 6 into 15 by 45. Okay, so that means 1 by 3, 2. So the corrected reticulocyte count is 2%. Okay, so that's very important, and this is one of the questions that is very, very important, and it is usually asked in exam always. So you should be knowing this. Okay, now let's go to the next question on the supravital stain itself. So on the supravital stain, now you are seeing this. What is this? So this is a supravital stain showing you this quickly. So this is a quiz I told you. What are these inclusions made up of? So everybody knows what is this. This is a golf ball inclusion. Golf ball inclusion. So who's going to tell me what is the golf ball inclusion made up of and where do we see it? Quickly, golf ball inclusion is seen in hemoglobin HbH. Okay, so it is seen in HbH disease. It's a type of alpha thalassemia. Very good. Okay, very good. But what is it made up of? No, it is not alpha 4. It is, remember, a very simple clue, it is beta 4. Okay, so it is beta 4. What is gamma 4 then? It is called hemoglobin Barts. Okay, so gamma 4 is hemoglobin Barts. So let's come to another question which you have to see here. So let me see how many of you can answer this. Hemoglobin HbH is associated with deletion of how many alpha genes? Quickly, how many alpha genes are deleted here? Yes, very good. So there are 3 alpha genes which are deleted here. Very good. Okay, 4 are deleted, then it is incompatible with life. It is hemoglobin Barts. Okay, that you have to remember. Okay, let's go to the next question here. So again, a supravital stain has been shown to you. Okay, and now this time you see the inclusions only at the tip, only at the margin as a dot, only as the margin as a dot. What is this? Okay, what is this? Quickly, again a supravital stain, but inclusion seen only at the tip, at the margin. Very good, Abhishek, you get full points. Heinz bodies. Okay, so these are Heinz bodies. Very, very good. Okay, so Heinz bodies are nothing but denatured hemoglobin. Okay, so it is a denatured hemoglobin. Okay, so denatured hemoglobin. Everybody very clear with this. Okay, so now let's look at how many of you can answer this question. Okay, very good. Try this question. Let me see how many of you can answer this. Which of the following condition does not cause pancytopenia? Question is does not. Okay, hypersplenism, aplastic anemia, megaloblastic anemia, G6pd deficiency. Very good, Ab Kumar, you get full point. The answer is G6pd deficiency. So remember, pancytopenia can occur due to 2 major causes. One is that either spleen is eating all the cells. Okay, so that is why there is no cell in the periphery. Okay, no cell means pancytopenia doesn't mean no cells. It means there is a cutoff. The hemoglobin is less than 10. Okay, the WBC count is less than 4,000 and platelet, okay, is less than basically it is less than 1 lakh. Okay, so I'll just write like. Okay, so that's pancytopenia. Okay, now if I am saying that there is less cells in the circulation, either the spleen is eating all cells, that is hypersplenism, or there is some problem in the bone marrow. There is some problem in the bone marrow. So remember, problem in the bone marrow, okay, can be very easily remembered as, okay, so it is Manish. M for megaloblastic anemia, A for aplastic anemia. Okay, M is also for, M can also be used for malignancies, if malignancies are infiltrating into the bone marrow, okay. N is nutritional, especially the megaloblastic anemias, which we have discussed, okay. I is immunological diseases like SLE, immunological diseases can also cause it. S is storage disorders can cause pancytopenia, and hypersplenism I have already told you, okay. So, megaloblastic anemia, malignancies infiltrating the marrow, okay. Then aplastic anemia, nutritional anemias, okay, especially the megaloblastic ones. I is for your immunological diseases, S is for storage, and H is for hypersplenism. Okay, so G6pd deficiency is actually a hemolytic anemia, and it will typically show you special cells in the peripheral blood which are called as bite cells. Okay, so G6pd deficiency will show you bite cells, and if you do a supravital stain, you will see Heinz bodies that you already know. Okay, now let's come to this smear here. Okay, so what are you seeing in this smear? So there is nucleated RBCs and there are myelocyte. Such peripheral smear picture is called as leukoerythroblastic blood picture. Whenever you are seeing these cells along with this, look at this cell everybody. This is a teardrop cell, okay. Teardrop cell with shift to the left, that is leukoerythroblastic blood picture with teardrop cells. What will be your diagnosis? Teardrop cells with leukoerythroblastic blood picture. Anybody who will tell me the answer to this question? Teardrop with leukoerythroblastic blood picture, what is your diagnosis for this? Quickly. Come on, quickly tell me what is the answer to this. Come on guys, tell me. Okay, very good, Tamil Selvan. One is myelofibrosis. Good. Very good, Sensoe. Anything else? Myelofibrosis. Apart from that, even myeloophthic anemias. Okay, even myeloophthic anemia. So, who's going to tell me what is myeloophthic anemias? That is like some, let's say patient has carcinoma breast and it infiltrated into the bone marrow. So, that will also cause, that will also cause leukoerythroblastic blood picture, right? Myelofibrosis is definitely the first option. Okay. Okay. Now, coming to the next question, okay. So, this is a 26-year-old pregnant woman presents with weakness and fatigue. On our admission, her MCV is 60, MCH is 26, MCHC is 32, okay, and CBC is performed, okay. So, what are the morphological findings here? So, can you see here, this is a pregnant female, can you see this? This is a pregnant female and her MCV, MCH and MCHC is decreased. So, what will be the peripheral smear finding here, okay? So, what should be the answer here? So, whenever the MCV, MCH, MCHC, everything is decreased in a pregnant female, so you should expect hypochromic RBCs. You should see hypochromic RBCs, okay? Right. Okay. Now, look at this, okay? So, if you look at this peripheral smear picture, what are you going to see is, can you see these small cells here? Yes. So, these cells are actually small cells, that is microcytic. But look at the hypochromia of the cell, it is more than 1/3, it is more than 1/3, okay. So, whenever there are small cells with more than 1/3 pallor is seen, so these are microcytic hypochromic cells which can be seen in, okay. So, what are the causes of microcytic hypochromic anemia? Remember, it is SITA, okay. Sideroblastic anemia, iron deficiency anemia, thalassemia and anemia of chronic disease. 1, 2, 3, 4. Okay. So, very good. Okay. Sideroblastic, iron deficiency, thalassemia and ACD are very important causes of microcytic hypochromic anemia that you have to remember. Okay. Okay. Now, let's come to this. Which of the following is not a cause for basophilic stippling? Okay. So, everybody remember this, okay. So, whenever we are talking about basophilic stippling, okay. So, basophilic stippling is basically nothing but they are just the inclusions, okay. They are just the basically RNA and ribosomal inclusions in the red cells, okay. Very good. Very good. So you have to remember, whenever I'm talking about these basophilic stipplings, it has to be seen. It has to be seen. Remember, it has to be seen in certain conditions where there is ineffective erythropoiesis. Okay. So this is typically seen in ineffective erythropoiesis. Okay. So whenever I'm talking about conditions of ineffective erythropoiesis, remember, one of them is thalassemia. Very good. Megaloblastic anemia. Very good. So these are the conditions of ineffective erythropoiesis, number 1. Number 2, you have to remember lead poisoning. Very good. GSR vlogs, very, very good. Lead poisoning. Okay. So lead poisoning, lead basically inhibits pyrimidine 5 nucleotidase. Okay. So whenever there is pyrimidine 5 nucleotidase deficiency, okay, whenever this enzyme is blocked, this is the final enzyme that eats up the last, RNA and the ribosomes. So when it's not able to eat it up, this will remain as basophilic stippling. So whenever somebody asks you about basophilic stippling, remember ineffective erythropoiesis, okay, and the second is lead poisoning, that is pyrimidine 5 nucleotidase deficiency. Okay, now let's come to the spot images, everybody. Can you see here? Okay, so this is Heinz, So whenever these inclusions, single inclusion is seen in the RBC, so till now we have seen that when on supravital stain, we saw this. On the supravital stain, if in the periphery, one single inclusion is seen like this, so this is called Heinz body. Whereas, if I am talking about Romanowski stain, like Giemsa or right Giemsa stain, and if you see a single purple colored inclusion like this is a nuclear remnant. Okay, so that means the nucleus has been left. This is typically called as this inclusion, which is here called as. Anybody who can tell me this quickly? What is this? Anybody? Very nice, Amia Nayak. Perfect. You gave the perfect answer. This is a Howell-Jolly body. So this is Howell-Jolly body. So all these inclusions are a feature of ineffective erythropoiesis. Okay. Look at this inclusion. This here. Can you see this? In the RBC, there is a ring. This is nothing but a mitotic spindle. Okay. So this mitotic spindle in the RBC, whenever you are seeing, this is actually a Cabo ring. Okay, so they can ask you what is this? Cabo ring is nothing but a mitotic spindle. Okay, Howell-Jolly body is nothing but a nuclear remnant. Okay, and in the RBC there are some stipplings which are there. Okay, so these are basophilic stipplings. Yes, of course. So they are a feature of ineffective erythropoiesis. And another place where you will see a lot of these is post-splenectomy. Why? Because spleen is the organ which is going to eat them. Okay, eat these abnormal inclusions. So if there's no spleen, nobody is going to eat it up. Okay, so remember, ineffective erythropoiesis and post-splenectomy are two important conditions where you see this. Perfect, everybody. Now let's go to the next question. Okay. So a child presents with difficulty in eating due to jaw swelling and there are enlarged cervical lymph nodes. The lymph node biopsy is shown. What is the diagnosis? What are you seeing here? Anybody who will tell me the answer first? What is the answer to this question? Quickly. What is this? This is tumor. And you can see this is a blue tumor. Okay, cells are very, very blue. And in between that blue, these are some, these are some whitish pale cells, macrophages, which are white colored and the background is blue. So what is this called? Starry sky appearance. Very good, Abhishek. Perfect. Starry sky appearance, and stars are your macrophages and sky is your blue cells here. So this is a starry sky appearance which is characteristically seen in Burkitt's lymphoma, Is everybody clear with this? That's characteristic for Burkitt's lymphoma. But if I say, if you see individual cell of Burkitt lymphoma, what is it like? So before we go to clinical, first look at the cells here. So look at these cells here. So these cells look like large cells. They are approximately, they were so large that earlier they were called as L3 type of ALL. Okay, they are very large cells. They are like lymphoblasts and all of them have peripheral inclusion. They will have vacuoles, peripheral vacuoles. And who will tell me what does this vacuole contain? This vacuole contain lipids. Okay, and they are therefore positive for oil red O. Okay, so oil red O is the stain for these vacuoles. Okay, so starry sky appearance and large cells with vacuoles in the blast, that's very typical of Burkitt's lymphoma. So here is the appearance of the child. Okay, the question that I had given, he has a jaw swelling and because of this he had a symptom. So the question is, how many of them are associated? So such patients who has jaw swelling, okay, how many of, what is the percentage of EBV infectivity in this case? Who's going to tell me that? How percentage of EBV positivity in this case? Anybody who's going to tell me that? Quick. Anybody? Okay, so that's an African child. Very good. Yes, hydroxycobalamin. Perfect. That's an African child. So what is this? How much percent is EBV positive in this? 100%. Okay, my dears. So this is a 100% EBV positivity whenever this is an endemic type of Burkitt. So whenever we have endemic type of Burkitt, very good, Prashant. Okay, that's 100%. Good, Vicky. Okay, whereas when we talk about two other types of Burkitt, so we have two other types of Burkitt, sporadic and HIV associated. Okay. Okay, so sporadic typically occurs in ileocecal region. That's the site where it occurs. So remember, ileocecal region. Whereas HIV can occur in any organ, okay, of the body. And in HIV, it is approximately 20 to 30%. And ileocecal is approximately 15 to 20%. Okay, EBV positivity. Okay, so whenever I am talking about EBV positivity, it's sporadic, which occurs in ileocecal region, or it is in HIV, which occurs in any organ of the body, or endemic is only 100%, that you have to remember. Next question, what is the translocation seen in Burkitt's? Quick, everybody, I'm waiting. Translocations in Burkitt. Quick. What is it? Translocations of Burkitt, quickly, guys, come on. Very good, Abhishek. 814. What else? 28 and 822. Please remember, all these are basically Burkitt's. And remember, what is present on 8? It is c-MYC. Okay. c-MYC is present on chromosome number 8. Okay, so remember, c-MYC is present on chromosome number 8. That's very characteristic. Okay, so whenever c-MYC goes to immunoglobulin heavy chain, that is chromosome 14, it causes Burkitt, or it can go to kappa and lambda light chains also, that is kappa and lambda light chains, so then also it's Burkitt. Okay, all these are translocations of Burkitt. So when we are talking about viruses, okay, so EBV associated lesions, look at this question. Again, one of the very favorite question of the examiners. So look at it. So a 14-year-old boy presents with enlargement of bilateral cervical lymph nodes, and a biopsy from the lymph node reveals the following picture. This is the picture. Which of the following is the correct set of diagnosis and etiology of the cell described? What are these cells? So definitely this is a binucleate cell. Very good. This is a binucleate cell. And remember the catch point here, everybody. It has a eosinophilic nucleoli. It has a eosinophilic nucleoli. And yes, it has, basically it's called as Auli nucleus. Okay, so binucleate with an eosinophilic nucleoli. This is very characteristic, or characteristically called as Reed-Sternberg cells. So these are nothing but Reed-Sternberg cells, and they're characteristically seen in Hodgkin's lymphoma. They're characteristically seen in Hodgkin's lymphoma. These are classical RS cells. Okay, so yes, so this is a Hodgkin's lymphoma. Associated virus is Epstein-Barr virus, and the Reed-Sternberg cell is there. Okay, yes. Okay, yes, definitely. So quickly, yes, Saptarishi, anything can come. Treat it as a quiz, and I'm going real fast so that I don't waste your time, so that we can quickly see as many questions as possible. Okay, so everybody should know this chart very nicely, everybody. Okay, so you take a snapshot of this. It's very important, everybody. So you know, we have a classical Hodgkin's and we have a non-classical Hodgkin's. So whenever I'm talking about classical Hodgkin's, everybody should remember here, classical Hodgkin's is basically mixed cellularity, nodular sclerosis, lymphocyte rich and lymphocyte depleted. Whereas non-classical is lymphocytic predominant Hodgkin's, also called as nodular lymphocytic predominant Hodgkin's lymphoma. So please guys, you have to remember that why is it differentiated, why the classical and non-classical was separated, was because non-classical has a very good prognosis, excellent prognosis, is of lymphocytic predominant. That's the first thing, okay. Second, the markers are different. So whenever I'm talking about non-classical type of Hodgkin's, it's not associated with the Epstein-Barr virus, and it is positive for CD20, EMA and CD45. So it's positive for CD20, CD45 and EMA. Whereas, whenever I am talking about classical Hodgkin's lymphoma, remember they are positive for CD15 and CD30. So, CD15 and CD30 is a marker for classical Hodgkin's, okay. Okay. So, whenever I am talking about mixed cellularity, it has a classical RS cells, nodular sclerosis, okay. Nodular sclerosis, whenever I am talking about it, Bhavin, this session will remain. Don't worry, you can revise it whenever you wish to. I will not delete this session, okay. So, whenever I am talking about nodular sclerosis, remember it is EBV negative, and it has lacunar cells in it, okay, lacunar cells in it, okay. Remember, lacunar cells are there, and name is nodular sclerosis. Why is it called sclerosis? Because there are collagen bands in it, okay. So, because of the collagen band, it is sclerosis. Lymphocytic rich means it's rich in lymphocytes. So, there are lots and lots of lymphocyte here, and it has a mononuclear cells. Remember, when you cut one eye of the owl and only one eye is left, that's called Hodgkin cell, okay, or a mononuclear cell. Lymphocytic depleted, basically it's depleted, dead. Dead is like, you know, like mummies of the Egypt. So, it's like a mummified cell, okay, or like an apoptotic cell, okay. So, that's a lymphocytic depleted, and it has a worst prognosis, okay. Whereas lymphocytic predominant has lots and lots of lymphocytes in the background, and they're very happy because they're going to have a super good prognosis. So, they eat popcorns. So, popcorn cell or LNH cell, lymphocytic and histocytic cell, and popcorn cell is the typical name of lymphocytic predominant, and the background is made up of B lymphocytes. The background is made up of B lymphocytes. So, the background is B lymphocyte, whereas in all the others, the background is not of B. So, remember, when we talk about it is background which is most important. So, name is on the background. Mixed cellularity means it has a mixed background of lymphocyte, eosinophils, T cells and all that. Nodular sclerosis has a background of collagen bundles. Lymphocytic rich, how is it different from lymphocytic predominant? Because in lymphocytic rich, the background is of T lymphocytes, not of B lymphocyte. Whereas lymphocytic predominant has a background of B lymphocyte. And lymphocytic depleted has a very poor prognosis. It has a mummified cells. So, there are no lymphocytes in the background, right. Okay. So, look at the images. You know this. This is a classical RS cell. These are the lacunar cells. These are the single nuclei Hodgkin cells, and these are the multilobated like this. So, popcorn cells or LNH cells. Okay. So, because the background of lymphocytic predominant is made up of B lymphocyte, remember, the first love of B lymphocyte is PAX5, okay. So, it's strongly PAX5 positive. So, they can ask you this as a question, which Hodgkin's is most strongly positive for PAX5? It is lymphocytic predominant Hodgkin's, okay. And that's your mummified RS cells. Please don't forget to recognize this cell also. This is a mummified RS cells, okay. Let's come to the next question, guys. Let me see how many of you can answer this question, okay. So, this is little tricky, but let me see how many of you can answer this quick question. So, this is a premature newborn baby and it requires transfusion, and he was transfused at some local hospital, and after transfusion he got respiratory distress and he died. What is the diagnosis? Very good, Abhishek, you get full points in this, okay. So, this is a cell here, it shows you a big nuclear inclusion, a perinuclear halo and a lot of cytoplasmic inclusions. So, this is very typical of CMV virus. Very nice, guys, CMV virus. Now, question is not CMV. Here the question to me is, why did he die out of transfusion? What transfusion would he have got that he died, okay, and how did he got CMV infection? So, let me see who can answer this question. So, why did this premature child got CMV infection after blood products? So, who will answer that question? Okay, Saptrishi, but why? Why? Question is why? Why did he got? So, remember, CMV usually travels with WBCs, okay. So, whenever we are giving blood to the newborns, okay, especially to the premature babies, we have to give them leukodepleted blood. Remember always. Okay, so all the newborn babies should be given leukodepleted blood. If you don't give them leukodepleted blood, okay, WBCs has a chance of carrying the CMV, and it can cause CMV infections in them. Okay, so remember, leukodepleted blood saves you not only from allergic and febrile reactions, but it also saves you from CMV infection. However, leukodepleted blood does not save you from graft versus host disease. Remember that point always. Okay, so for prevention of graft versus host disease, you have to give irradiated blood. You have to give irradiated blood. Now that's a very, very important point you have to remember. Okay, so everybody should be very clear in differentiating these two images. Okay, that's the classical RS cells where you have large eosinophilic nuclei, and look at this cell. In this, with large nuclear inclusion is there with the perinuclear halo and lot of cytoplasmic inclusion. So this is CMV. So CMV can also have Auli inclusions that everybody should remember. Okay, remember the filters, guys, because this is very important. So whenever I'm talking about leukodepletion, you should know the filters also. So we have 3 generation filters: first generation, second generation, and third generation. Okay, so third generation filters are actually the leukocyte filters. Remember, this image can come in your exam. This filter here is a leukocyte filter. Okay, leukocyte filter, which you have to remember. Look at the second generation filter. It has a size of 20 to 40 micrometer, and it is a micro aggregate filter, which you see, and it is only for filtering, you know, WBC, platelet, fibrins, and all that. What about first generation filter? This is the filters which you see like this normally, and this is 170 to 250 micrometer filter, and this is also called as clot filter. Okay, so this is also called as clot filters. Okay, right. So these are the type of filters that we have in our country, and we should be knowing it. Okay, 170 to 250 is your classical filters. The second generation is 20 to 40 micrometer, just for removing that fibrin threads and all that. And third generation is leukodepleted filters. Very good. Okay, let's come to the next question here. Let's see. So Saptrishi told me about pneumonia. So let me see if he can answer this. Okay, so this is a lung biopsy from a pneumonia patient, and he shows this giant cell is seen. What is the etiology of this cell? Quickly, everybody. What is this giant cell? So can you see this giant cell, everybody? What is the classical feature? So every nucleus here is showing inclusion. So it's a giant cell where every nucleus shows you inclusion. Okay, so this is Warthin-Finkelcy giant cell. Okay, and this giant cell is typically seen in measles. And this measles pneumonia is what is called as H pneumonia. H pneumonia is a pneumonia which is caused by measles. Now it is very, very rare because most of the children are have vaccinated. Okay, somebody said HSV. Guys, remember, HSV has a very classical inclusions. Okay, so that's called 3M. Okay, so they are multinucleated, but they show you margination and molding. What is a molding? What do you mean by molding? That means one cell is fitting into the other. So one cell indents and the other cell fits into it. So that's what is called as a molding, like this: molding, margination, and multinucleation. Okay, multinucleation. So there are multiple nucleus, molding, and margination. Perfect, guys. That's very classical of HSV. Now coming to the next question. Okay, so this is a 33-year-old male. Okay, let's say presenting with the 5-week history of calf pain and swelling and low grade fever, and his muscle biopsy showed lots of eosinophils. So it's a very simple question. Okay, which interleukin is responsible for eosinophilia? Quickly, everybody, what is the answer to this? I know everybody knows this. This is interleukin 5, but you should know the other interleukins also, guys. So interleukin 2 is basically produced by the T lymphocyte, and it goes and stimulates the T lymphocyte production only by the paracrine loop. It can also stimulate the NK cells. Okay, and it can also stimulate the T regulatory cells. So these are the 3 functions of interleukin 2. Okay, so interleukin 2 is basically paracrine for T cells. It stimulates NK cells and the regulatory T cells. Interleukin 4 stimulates B cells to produce immunoglobulin E. Okay, and interleukin 6, everybody knows that this is a very important interleukin which basically stimulates acute phase reactants from the liver. So, hepatocytes have interleukin 6 receptor, okay, and all the acute phase reactants can be released by interleukin 6. That is why COVID infection, they said there is a high role of interleukin 6 because lots and lots of interleukin 6 was released in that. Apart from that, in multiple myeloma also, interleukin 6 has a major role. In multiple myeloma also, interleukin 6 has a major role, right? Okay, guys. So, that was your interleukins. That's a chart which you can, go on later. This is what I have told you in the gist, okay? Let's go to the next question, which is a very practical question and can be asked to you in exam. Which of the following is characteristic of exudative pleural effusion? Which is the characteristic of exudative pleural effusion? So, whenever I am talking about exudative pleural effusion, you should have the pleural fluid protein by serum protein more than 0.5, and also, so that's the characteristic. Apart from that, remember pleural fluid LDH by serum LDH should be more than 0.6. So, this criteria is called as Light's criteria. Okay. So, what do you understand by the Light's criteria, guys? So, this is the criteria. Light criteria is the criteria to differentiate transudative effusions from exudative effusions. So, whenever you have to differentiate transudative from exudative effusion, you have to use Light criteria. And in this, the criteria is that if it is an exudate, then the protein of the pleural fluid and LDH of the pleural fluid will be more. Okay, and the cutoffs have been defined as 0.5 and 0.6. Apart from that, if you don't take a cutoff, you just do LDH of the pleural fluid, then it will be more than 200. Then it will be more than 200. So, which criteria differentiate exudative versus transudative effusion? It's Light criteria, which everybody should know. Okay. Right, coming to the next question. Okay, let's see this. So, 30-year-old male presents with enlarging mass in the wrist associated with tenderness, and the cut section of the radius has been taken, and it shows a histopathological image. This is the image that has been shown, okay, and it shows you lots and lots of giant cells, okay, and yes, okay. Saptrishi, I told you, it was just the Light's criteria and you have to just pick up the difference between exudative and transudative. So, answer is A in that, okay, right. So, if you look at the X-ray, it has a soap bubble appearance and there are lots and lots of giant cells here. So, what is the answer to this question, everybody? It's a giant cell tumor, also called as osteoclastoma. Guys, I have to ask you a question. What is a malignant component here? Is it a giant cell or the stroma? Remember, stromal cells, okay, are the malignant counterpart here. So, stromal cells are the malignant counterpart here, which you should always remember, okay. So, we have giant cells and stromal cells or mesenchymal cells are the malignant cells here, okay, right. If we talk about the other options, look at the images which you should remember. Remember this pink color material which is in between the cells, this is called as lacy chromatin. Okay, this lacy chromatin is very lacy osteoid, okay, lacy osteoid. So, somehow chromatin is roaming in my brain, okay. So, lacy osteoid is very characteristic feature of osteosarcoma. So, osteosarcoma typically shows you lacy osteoid, whereas if you are seeing this just blue cells, sheets and sheets of blue sheets of cells, okay, cells, blue sheets of cells with having, some of the cytoplasm is clear. Can you see the cytoplasm of the cells is little clear? This is because they contain lot of glycogen. It contains lots and lots of glycogen, okay. Okay, so it's an autoimmune disease, Saptrishi. In autoimmune diseases, you can have calf pain and eosinophilia, or it can be a cysticercus infection, you never know, which can cause calf pain, okay. So, that's the answer to that question, okay, right. So, blue sheets of cells with presence of glycogen in it, cytoplasm, that's very typical of Ewing's. So, remember, Ewing's sarcoma is one sarcoma which is very strongly positive for past stain. Why is it positive for past stain? Because the cytoplasm contains lots and lots of glycogen. So if you look at the INICT question also which came this time, this is not the direct question but sort of that question only. So it was that again it is showing just the sheets of blue cell, and they had given that this tumor is positive for MYC2, or they can give you positivity for CD99. So this is very characteristic morphology and IHC for Ewing sarcoma. Okay, and it typically shows you onion skinning, that you all know. Okay, perfect, right. So that's your Ewing's. Okay, so that was the other option that you should remember. Let's look at how many of you can answer this question now. Okay, so a child presents with osteogenesis imperfecta and he has blue sclera. Okay, but his brother does not have blue sclera, he shows multiple fractures instead. What is this feature suggestive of? What is this phenomena called? Let me see how many of you can answer this. What is this called? So one brother is having blue sclera, the other brother is having multiple fractures. What is it called? What is it called? This is called variable expressivity. Okay, so you have the gene but you express it differently in different individuals. That's called variable expressivity. Okay, what do you understand by complete penetrance? Penetrance means when you have the gene and how much the child is showing. Okay, complete penetrance means like thalassemias, autosomal recessive disorders have complete penetrance. Like that means a patient is a thal major. If he doesn't have beta genes, he will have the classical thal major presentation. He'll require blood transfusions. He'll have, you know, all the problems of thalassemia major. So that's what is called as complete penetrance. Okay, so penetrance means if you have the gene and how much of it is expressing. Okay, that's penetrance. Okay, so autosomal recessive disorders have complete penetrance. Okay, so all the inherited disorders of metabolism are autosomal recessive and they usually have complete penetrance. If there's a gene defect, person will definitely have a disease. Whereas autosomal dominant disorders have incomplete penetrance. That is, even though they have the gene, they will not express it, they will not show it completely. Yes, heteroplasmy. Where do you see heteroplasmy? Mitochondrial disorders. In mitochondrial disorders, the diseased and the normal mitochondria can coexist in a person. That is called heteroplasmy. Okay, and what is that anticipation? Anticipation is very good. Who said this answer? Saptrishi. Okay, in trinucleotide repeat mutation, the anticipation phenomena is there. That is, with every generation the symptoms are going to go worse. So you can actually know, you can actually anticipate how the next generation is going to come. So trinucleotide mutation is a dynamic mutation, and with every generation the mutation is going to go severe, right? Okay, now this is a very practical question which they can ask you in exam. Can you tell me the answer to this question? Which of the following regarding bone marrow biopsy needle and for the procedure is not true? Which is not true? Quick everybody, which is not true? It can be done in prone or lateral position, that's true. It can find infiltrative and granulomatous disorders, perfect. Breath holding is not necessary, perfect. Platelet count of 40,000 is a contraindication, wrong. So platelet count, thrombocytopenia is not a contraindication for bone marrow biopsy. In fact, you know, for diagnosis of ITP patients, you do bone marrow biopsy and aspirates, isn't it? So definitely, even if the platelet count is less, in fact, if the platelet count is less than 20,000, we can give platelet transfusions and do bone marrow biopsy. So it's not a contraindication at all. Okay, it's not a contraindication at all. Okay, everybody clear with this? Yes. So if somebody asks you what is an absolute contraindication for bone marrow biopsy, absolute. So there is no absolute contraindication until unless a patient has, you know, severe hemophilia where he can bleed extensively. So then you have to give factor support and then do bone marrow. Okay, so that's only condition which I remember, right? Okay, look at this needle everybody. What is this needle? Who's going to identify this needle quickly? What is this? This is called Sala's needle. Sala's needle, how do you identify? It has a screw. So can you see the screw? So if the screw is there, then it is Sala's needle. Very good, Saptrishi. If the patient refuses, then also you can't do the bone marrow. Yes, consent is very important. Yeah. And look at this. If there is no screw here, then it is Klima needle. So you have to see the screw. Okay. So if no screw, Klima. If screw is there, Sala. And look at this needle here. This has a cap like this. This is Jamshidi's needle. Okay, Jamshidi's needle, it's for bone marrow biopsy. Okay, so it is for bone marrow biopsy, right? Okay, let's look at the next question. Okay, so this is a 30-year-old smoker who presented with productive cough, fever and recurrent pulmonary infection, and after the death, okay, after the death, which of the following components are destroyed? So look at these. So how do you say that this is a bronchiectasis? First of all, see, the whenever your bronchi are reaching till the pleura, okay, so this is the pleura and your bronchi are reaching till the pleura, that is very characteristic of bronchiectasis. Okay, so bronchiectasis means dilated bronchi reaching up to the pleura, that's very characteristic of bronchiectasis. And if you want to identify how does this happen, what happens here is, so definitely there is an infection and an inflammation that destroys everything, cartilage, muscle and elastic fiber, so it destroys all of the above. So remember here, look at the diagram here of bronchus, there is an epithelium, there is a lamina propria, okay, and just there is a muscle here, there is a seromucinous glands and then there is a cartilage. So everything is destroyed whenever there is an inflammation and infection. Remember here, it can occur either because of idiopathic or it can occur because of cystic fibrosis and sequestration or cartagenous syndrome. Infections like, you know, bacterial like TB, viral like influenza, fungi like aspergillosis, bronchial obstruction, there is an obstruction that can also cause destruction like tumor, foreign body and mucus plug, and others like rheumatoid arthritis and SLE. All these can cause bronchiectasis and it can cause destruction, and here your bronchus reaches till the pleura, that's the catch point. Now one of the very favorite question of the examiners and everybody asks them always, the morphological finding of kidney is shown and it is associated with which of the following conditions? So everybody, you know this, that here there are small spots all over the kidney and this is what is called as a flea bitten kidney. Okay, so this is what is called as flea bitten kidney because it has small pinpoint hemorrhages which you can see here. This is a flea bitten kidney and it is very classically seen in malignant hypertension. It's classically seen in malignant hypertension. So if we look at the causes of flea bitten kidney, remember the point here is World Health PSM. So it's basically seen in vaginous granulomatosis, it can be seen in henoch-Schönlein purpura, it can be seen in PSG and also yes, bacterial endocarditis and malignant hypertension. So these are the causes of flea bitten kidney, and remember malignant hypertension is one of the favorite question of the examiners which they ask you, right? Okay, let's look at this question and let's see how many of you can answer this question. So this is a 58-year-old female. He presents with upper abdominal pain, and whenever you put an endoscopy, you see a yellowish submucosal mass. That's a very important point here. Submucosal mass is seen here, and what do you see here? Spindle-shaped cells are seen. Which of the following is most likely diagnosis? Okay, so spindle-shaped cells are seen here. Okay, what is the diagnosis here? So remember, spindle-shaped cells, whenever you're seeing in a submucosal mass, very good everybody, it has to be GIST. Okay, so who answered it first? Rajya Guru, perfect. Rajya Guru vlogs, it's perfect answer, it's GIST. Okay, so what is the marker which you will use for this? CD117 and DOG1. And what is the gene here? c-KIT. What is the enzyme mutation? SDH. Okay, so succinate dehydrogenase is the enzyme which is associated with GIST. Okay, especially in the pediatrics GIST. And of course, you know, cells of Kajal basically stimulated. Okay. So identify the technique. This was again an INICET question, and I hope all of you know this is nothing but a very simple question. This is fish. Okay, fluorescent in situ hybridization, and see here, what do you see? Two red signals and two green signals. This is normal. Whereas here you are seeing two yellow signals. That is whenever the red and green juxtapose on each other. That's a translocation. It can be 922. If I say that red was 9 and green was for 22, then it becomes 922 translocation, that is CML. Or if I say 1517, that is, let's say red was 15 and green was 17, then it becomes 1517 translocation, and that is APML. Okay, so this yellow signal always indicates there is a basically translocation which is occurring here. So that's your fish. Okay, remember PCR basically, PCR is a different technique. There are lots of PCR. It's based on amplification methodology, immunohistochemistry. Everything will appear brown. Anything that is brown is positive. And NGS is next generation sequencing, which is basically seen, and it's a very fast technique, okay, which can sequence the molecules very rapidly. Nowadays we are using NGS mostly to identify the genetic transformation. Everything has its own advantages and disadvantages. Okay, blood banking. Identify the blood group in this person quickly. So that's a very rudimentary technique now. That is, it's actually a slide method, but they can ask you this. So you can see here, this is the control. First, always you should see the control. If there is no agglutinates on the control, that is very important, because in cases of autoimmune hemolytic anemia, there will be agglutinates in the control. So if control doesn't have agglutinates, that means this is not an autoimmune hemolytic anemia, it is out. Now look at the other places where agglutinates is there. So A and D are showing agglutinates. So that means this patient has blood group of A positive. B is not having any agglutinates. So that's A positive. Okay, so here I want to highlight the point of control. Okay, so control always must be seen. Okay, right. Now this is again another technique that is very popular for examiners, that they give you fishnet pattern. So fishnet pattern is basically, this is a immunofluorescence which we use. Okay, this is technique is immunofluorescence, and whenever we put it on tissues, this is usually called as direct immunofluorescence. And everybody should remember here that the dye that we usually use is FITC, that is fluoroisothiocyanate. And always you should remember here that basically in this the antibodies are against anti-desmoglein. Okay, so this is desmogleins that we target. Okay, so desmogleins are present in between the cells, so all these antibodies are highlighted. Okay, so that is why this is seen. Desmoglein especially 1 and 3 are most important in cases of pemphigus vulgaris. Remember, so these are pemphigus. Remember, all the types of pemphigus will show you fishnet pattern. Okay, that's a very important point you have to remember. Whereas bullous pemphigoid, if they are asking about, it will show you a linear pattern, because here in bullous pemphigoid the antibody is against hemidesmosomes. Okay, so the antibody is against hemidesmosomes, which is present at the junction of epithelium and the basement membrane. Okay, and Behçet's has a lot of neutrophils in the biopsy, right? Yes, Saptarshi, 3 is more than 1. Okay, so next question is CNS. Which of the following is a very important risk factor for the tumor shown below? This question was asked in the NIMHANS, and I have also added it in my book also. And very important question, what is the most important risk factor for this tumor? So first you have to identify the tumor, isn't it? So what is this tumor? So this is brain, and this is some tumor which is coming from outside and compressing the brain. So this is a tumor which arises from the meninges. It is meningioma. And if you look at this, it's showing you these bodies. What are these bodies called as? Sarcoma bodies. These bodies are called as sarcoma bodies. Okay. And the most important risk factor here is your radiation. Very good, Mohan Singh. You get okay, right. So it's very good. So it's radiation is the most important risk factor. Very good, PK Yadav, Priyanka, everybody. Okay, who answers? If we are talking about gene, which is the most important gene associated? NF2. So NF2 is, remember NF2 is associated with schwannoma, ependymoma and meningiomas. Okay, so remember schwannoma, ependymomas and meningiomas. SEM. So NF2 is associated with SEM. Whereas if somebody asks you what is NF1 associated with, so it is associated with neurofibroma and optic gliomas. Okay, so NF1 is associated with neurofibroma and optic gliomas. NF2 is associated with SEM, schwannoma, ependymomas and meningiomas. Okay. Okay, coming to the next question, which organ has red infarct? If somebody asks you, so first, what is this organ? Okay, so everybody, this is a kidney. Okay, so you can see the here you can see the rays, medullary rays here. Okay, and this is the kidney, and it shows you a wedge-shaped infarct. Wedge-shaped infarct is typically a white infarct. Okay, wedge-shaped infarct is typically a white infarct that you have to remember. Okay, this is very typically image of kidney. So white infarcts are typically seen whenever there is an arterial occlusion or a single vessel inclusion, okay, on a solid organ. So especially like spleen, heart, okay, brain and kidney. So brain can get hemorrhagic infarcts also, but mostly it is white infarcts. So spleen, heart and kidney typically shows you white infarct, whereas loose organs like lungs, okay, shows you red infarct, okay, with double circulation like intestine gets red infarcts, okay. Liver has chances of getting both white and red infarcts, but red infarcts are common. And torsion, whenever there's venous occlusion, okay, so torsion causes venous occlusion, so venous occlusion congests the organ and it causes red infarcts. So that's torsion of the ovary and the testis, okay. Yes, so that's the zoom image here. So somebody asks you, where do you see white infarcts? So white infarcts are typically seen in spleen, heart and kidney, whereas red infarcts are typically seen in lung, intestine. Remember, liver can show you dichotomous infarct, that is both the type of infarcts, and torsion of ovary or testis can show you red infarcts, right? Okay. Coming to the next question. So breast, coming to the next question, next organ, breast, okay. So this is a biopsy taken from breast and it is suggestive of what lesion? Okay, can you tell me it is suggestive of what lesion here? So here what do you see? This is a tubule and this tubule is filled with tumor cells. This tubule is filled with tumor cells, okay. So that's a very classical, that's a very classical for your lesion, okay. This is in situ lesion. Till the time the basement membrane outside is intact, okay, it's not an invasive carcinoma, then it is called as in situ carcinoma, okay. So DCIS, okay, so whenever we have carcinoma in situ, we see cells which are present inside the basement membrane, and remember the center part of this has necrosis, okay. So center part of it has necrosis. So whenever the central part of this tumor cells undergo necrosis, this is what is called as a comedocarcinoma, okay. This is what is called as a comedocarcinoma, okay. Everybody clear with this? So if somebody asks you, this is a lesion suggestive of, remember it's a comedocarcinoma, there's a central necrosis and the tumor cells are like that, surrounded there. So that's a very typical picture of carcinoma in situ. Can you identify these two images, guys? Yes, these two images. So you can see a pattern here, that's a single file pattern which you can see here. That's a very characteristic of lobular carcinoma. So this is an Indian file pattern, single cells infiltrating, and I hope everybody knows the mutation is loss of weak adherent or loss of CDH1, okay. And what is this? These are the glands that have compressed into slit shaped like this because of expansion of the stroma. So stroma has expanded and because of this the glands have become slit shaped. This is very characteristic of fibroadenomas, okay. So fibroadenoma is one of the most common tumor of the breast. It's a benign tumor and it's a biphasic tumor, and remember stroma increases and the glands are compressed into slits. That's very characteristic, okay, right. So that's all guys for today, okay. So it was a short session, so I had some time, so I thought I'll take a session for you all. So I hope you liked it. Do tell me in comments you liked it or not, and if you want more sessions like this, do let me know, okay. And I'm happy to tell you that the new edition of my book will be coming up soon. It's just in the press and it will be released soon. You can follow me on my Facebook group, that is Dr. Vandana Pathology Study Circle, or you can follow me on Instagram for academic. All of you know my academic channel is Dr. Vandana Pathology and my personal channel is Dr. Vandana Puri, where there is no academics, it's only travel, okay, right. So everybody do well. Hope you do very well in your exams. All the very best guys. If you have any doubt, do drop in a message either on Instagram or on my Facebook group. I'll be happy to help you. All the best. Bye bye guys.